Morning, sir, and thank you for inviting me here. It has been a great learning experience for all of us, and sir has united everyone from all over India. And today, Dr. Poonam Malhotra from All India Institute of Medical Sciences, Professor, she has uh, a very good topic on pericardial diseases and echocardiography. And I invite her to start this session. Over to you, Mar.
Thank you, Parimala, and thank you, Dr. Mulli. It's indeed a pleasure always to come and be on this Sunday morning breakfast session on echocardiography. It is a great learning, and we all have been together at various forums for echo, but somehow this topic of pericardial disease, especially on transthoracic echo, is something that remained a bit neglected on our front till we realized the importance of pericardium becoming thickened and giving us a dilemma and a nightmare in the ICU in the form of a pericarditis acute or chronic, or a constrictive pericarditis or a cardiac tamponade. So greetings from my alma mater. I'll begin by saying that the normal pericardial wall thickness is just about 1 to 2 millimeters, and transthoracic is normally not the recommended measurement for pericardial thickness. It is the gold standard being the CT or the MRI. But according to the American and the European guidelines today, delineating the pericardial borders using a transthoracic echo or a transesophageal echo is something that is a boon in the hands of the echocardiographers. And who better than an anesthetist in the ICU as well as in the OR to discuss and detail us about the pericardium and how it reflects the normal physiology in the post-op period. So going on to constrictive pericarditis, if I say this and you can see the arrow moving around, this is the famous Beck's triad, where you have hypotension, distant heart murmurs, distant breath sounds, a raised JVP with a swinging heart. What do we see here? We see that there is the pericardial fluid all around the heart, which gives it a cushioning effect. And this pericardium also is thickened. You can see that the pericardium here is thickened. Now, the pericardium has a visceral and a parietal component to it. And this thickening is due to just fibrosis or granulations alone. It could be due to calcification in it. But thickening with calcification becomes a hallmark of constrictive pericarditis. Now, this pericardial effusion and the fluid here could be either a transudate, as you normally see in a patient with right heart failure or congestive heart failure, or it could be a fibrinous effusion, exudate, as you see in a tuberculous patient or in a patient of someone who has had fibrinous strands post-hemorrhage and post-blunt trauma. And this acute pericarditis remaining neglected has developed into a chronic pericardial effusion, giving it strand-like fibrinous structures beyond the heart. This is what will become absolutely, and this mesh kind of a system that it forms gives rise to the tamponade that one will have as an emergency, because this patient did not, after the trauma, resort to consecutive echoes to delineate this exudative nature of the pericardial effusion. Now, as I was saying, it is not just the transthoracic, but even the transesophageal echo, which will give this, as we see in panel A, the thickening structure to the pericardium in the RV free wall or in the LV free wall. And this is what we see in the first view here, which shows the aortic valve as well as the LVOT with the RV above and the LA below, RA above and the LA below in the parasternal short axis view. This is the long axis view, but it is the contrast CT which gives us the entire thickening as is witnessed all around the heart in the LV free wall area especially, which becomes the gold standard for measuring the pericardial thickening. So chest CT is the gold standard. MRI too will give you a thickened pericardium measurement much more than transthoracic or a transesophageal echo. Now, we are all well versed with this, that the pericardial pressure is a product of the pericardial stiffness. And what is this stiffness? The pericardial stiffness is the delta P upon delta V. Now, delta V is the pericardial stiffness, and it is inverse to pericardial compliance. So when we say that the pericardial pressure in a chamber is increasing, as it does in a constrictive pericarditis or in a cardiac tamponade emergency, what is happening actually? Something that is happening there is that the pericardial pressure has increased so much along with the increase in the volume. And you see that the slope of the intrapericardial pressure volume curve that we are going to see now is going to transmit this increase in intrathoracic pressure change into the pericardial space, which is restricted. So this is how, in a fixed cage-like situation, a kind of a physiological nature becomes a pathological change. So the amount of pericardial pressure inside the two visceral and parietal pericardium is just about zero. It's negative or zero, but it is never high. And so also the amount of fluid inside the pericardial volume. But under pathological conditions, when the pericardium becomes thickened, this intrapericardial change in pressure, which increases with the increase in the pericardial fluid, will also increase the pericardial stiffness. And at the same time, this will reduce the pericardial compliance. And this relationship between pressure changes with volume changes is non-linear. It's not linear. It has a flat part and then it suddenly rises. This nonlinear relationship increases that whenever the size of the pericardial effusion initially increases, it only moderately increases the intrapericardial pressure. But after a while, when there is a chronic condition setting in, this flat portion, once it has become a part of the linear portion, there is tremendous increase in both pressure with the change in the volume. As you can see here, the part A panel says that the volume that is increasing, the same amount on the flat part, raises the intrapericardial pressure till it is on the flat part very minimally. The delta P1 is very small. But the moment it is a linear rise, it becomes after a period of time, the same volume will cause marked increase in intrapericardial pressures, right? This is what happens in a constrictive pericarditis or a tamponade situation. And in a pericardial effusion, which is a chronic standing, the entire volume pressure curve with the stiffness will move towards the right. And this is a compensatory mechanism of the body. Now, when the intrapericardial pressure exceeds the pressure in any of the chamber during at least part of the cardiac cycle, and it occupies more than 1/3 of the cardiac cycle, the tamponade physiology develops. And even removal of a small amount, when we say we are doing a pericardiocentesis, we don't remove the entire pericardial fluid. Even a removal of a small amount of pericardial fluid will give a lot of relieving of the signs and symptoms of the tamponade. But as there is slow accumulation of the pericardial effusion, as happens in a chronic pericarditis, this pericardial stiffness also gradually will fall, and this falling of the pericardial stiffness will raise the pericardial compliance because the two are inversely related, and therefore the intrapericardial pressure remains near normal for longer periods, and that's how chronic constrictive pericarditis patients live on for a long time till they become in a tamponading stage, which may come on as an emergency. So I hope this pressure-volume relationship moving to the right is nicely understood. So here you see what are the views. We have the 5 major views: pericardial short axis, parasternal short axis view, as you see here, where you see an indentation of a part of the pericardium, where the fluid is all around the LV free wall. And this acute pericarditis situation with a small collection of fluid that you can see as the part of the asterisk, this shows around the visceral pericardial surface with any lack of any regional wall motion abnormalities. It's a complete akinesia that this small acute pericardial fluid accumulation causes along the LV free wall to the movement of the short axis of the LV. Now, this is taken from the apical 2-chamber view. You can use any apical view, a 2-chamber, a 3-chamber, or a 4-chamber, or a 5-chamber, which incorporates the iota as well. And once you see this, you will see it as an orange rind thickening. This thickening, which is echoluscent, it is very sharp in focus, will come on as a thickening with some collection of fluid around it. And this visceral pericardium is secondary to all inflammatory changes of acute pericarditis. This is seen adjacent generally to the lateral wall of the left ventricle. When you're moving from here, you should also do the parasternal long axis views. Now, when we are on the lower sternum of the left side, we can see the left ventricle very well. And in the parasternal long axis views, we will be able to see the echo bright calcified pericardium. As we see the echo leaflets, which are calcified very well on transesophageal or transthoracic echo, here also you can see with the black arrows, the leaflets very, very well. Let's see a case. The whole talk would be revolving around a few cases that we put together in this talk. Very often, any echo-free space can be misdiagnosed as a pericardial effusion. We came across a case which was a 20-year-old admitted to the hospital with shortness of breath and angina, with a pressure of 130/60 and pulse being 76, and a systolic murmur heard at the apical region. A difference of 45 millimeters of mercury was noted in the blood pressure between the upper and the lower limbs. And obviously, with this 20-year-old having a slight difference of 45 between the upper and lower limbs, we did think of a history of coarctation. A 2D echo was performed, and this 2D echo showed, as shown here, and marked S, a space which was adjacent to the left ventricle. Now you see the left ventricle in short axis, and this is the apical 5-chamber view, and you see a space which is marked S, which we thought is actually a pericardial fluid. And we sent this patient for a CT. Now, when we did the CT, we saw, instead of a red opaque kind of a structure, which looked more like a tube adjacent to the heart. And this was outside the heart, right? Now, what had happened was that this transthoracic echo that we did showed a severe AR with a large LV, which was measuring about 70 millimeters. And there was a coarctation of aorta of this patient in the left subclavian artery, which was confirmed by a cardiac cath. And the aortic valve was replaced with an AVR done along with coarctation repaired. Now, this patient is presenting now in the OT 2 months later with shortness of breath and collection of fluid. And this fluid is very, very minimal compared to the space that we are seeing, which is actually the graph which was juxtaposed in the coarcted areas during the repair. And there was a choledocholithiasis. This patient had a cholecystectomy done, and the patient was sent home. Now, this echo-free space, which can mimic the pericardial effusion of acute pericarditis, it, on careful examination, is actually a Dacron tube. And therefore, as I said, this was done earlier. So you should always have a CT with any space which is mimicking or looking like a pericardial effusion collection. And also how to differentiate this pericardial with pleural effusion will come in the subsequent slides. Let's see another patient. 25-year-old, initially with fever, myalgia, dyspnea, chest pain, small pericardial effusion and bilateral pleural effusions are seen on workup of this patient. So this is a 25-year-old presenting with both pericardial as well as pleural effusions, and repeat thoracocentesis are performed, and you see a transudative nature of the fluid, which is sent for cytology, and patient's breathlessness persists despite the therapeutic thoracocentesis. Additional diagnostic workup with echo and cardiac MRI is done. And when we see this, what do we see? This patient has a good ejection fraction of about 62%, and there's a biatrial enlargement with aneurysmal interatrial septum. And also, if you closely watch what is happening to the IVS, though there is an aneurysmal interatrial septum, and there is a biatrial enlargement, the LVs are rather small, and there is a shudder or a shaky or a shagginess in the mid-interventricular septum. This is a very, very pathognomic sign of pericardial effusion, and this is known as the septal bounce. So you have a ASD here with a septal bounce with some collection of fluid here all around the heart in the RV free wall, a minimal amount around the LV free wall. Always remember that the LA in the posterior side is devoid of pleura. So if you have any collection in the LA, it will always be more in the RA than around the LA. And the flattening of the RA that is so typical of a pericarditis is not seen with the LA thickening or a flattening as it is seen. We talk of diastolic collapse of the RA free wall, never of the LA free wall. So that is a take-home point, that the LA on the posterior side is deficient of the pleura, and pleural effusion and pericardial effusions may not happen so commonly on the posterior aspect of the LA as they would happen on the RA side. So when we go on to this, we went on to do the parasternal short axis views, which shows this very typical bounce here. This is the bounce here that you're seeing. It's a RA wall flattening here. You're seeing the LV, and that's the, around it is the bounce here. That's the IBS area. And you saw here the pulmonary systolic pressure is about 15. Now, to confirm that it's a pericarditis, the second part should be done, that it is a septal bounce, which is helping. What should be done? You should do the tissue Doppler velocities on the medial and the lateral septal side. So tissue Doppler septal and lateral E prime velocities are done. And we find that the medial septal velocities are more increased than the lateral velocities, which is a paradox. Normally, the medial are always less than the lateral velocities. So whenever you have a septal bounce, there is a respirophasic variation of the mitral inflow E wave velocities. And this is the respirophasic mitral inflow variation, that A and B are an increase in the expiration, and inspiration, it is decreasing. So this is called respirophasic expiration, inspiration, increase and decrease. Now this 2D echo, which is done to confirm the presence of a bidirectional secondum type of ASD, is showing a respirophasic inflow outflow velocity change, and a cardiac MRI confirmed the preserved LV function and a biatrial enlargement. We did a cardiac cath on this patient because the septal bounce, the increase in the medial velocities more than the lateral velocities, no evidence of myocarditis, diffuse thickening enhancement of the pericardium as shown in the gadolinium contrast imaging, and interventricular septal discordance, which you can very nicely appreciate here in the MRI itself, all suggested towards a constrictive pericarditis physiology. This patient underwent a total pericardiectomy and ASD closure of the atrial septum defect. The findings at the time of surgery indicated a dense mediastinal inflammation with adherent parietal and visceral pericardium, as you can see in the two differences of the pericardium in the two artery forceps. And this patient had a resolution of the symptoms which were not there when the thoracosynthesis were being done. So a high index of suspicion for constrictive pericardial disease should be maintained in a setting of presence of a right atrial collapse, which is best demarcated on doing an M mode across the right atrium. Presence of a septal bounce and presence of the medial tissue Doppler velocities at mitral inflow being higher. Normally, we say the velocity, medial velocity E prime is anything more than 9 centimeters, it is high. And if it is particularly more higher than the lateral velocities, because see, it's like a rib cage which is constricted. So what will move will be decreased movement in this restricted cage where the medial pressures will grow more than the lateral pressure. So it's very easy to understand. So this is a real world experience of pericardial disease in which clinical symptoms like the presence of a biatrial secondum ASD need a cardiac MRI, and that to a gadolinium enhancement to show the ventricular septal bounce, the shagginess of the ventricular septal bounce, to show the increase in the medial velocities over the lateral velocities, and also to show the right atrial inversion or right diastolic inversion. Remember, it is the diastolic filling on which the atrial filling is dependent upon, right? So in diastole, when you do an M mode, you see the M mode thickening being collapsed with small ventricles, large atria, as we saw in this case, with a fair systolic function of 60% ejection fraction, generally a low cardiac output because of restricted movement, a jerky interventricular septum, which is known as a septal bounce, which is seen very nicely here when we did the TE on this patient. And you can see here what's happening. Here, the thickening of the pericardium is so much with some amount of pericardial fluid. And there is a secondum ASD here that when we did the TE in the intraoperative period, this patient benefited a lot. This is the transthoracic echo where the LV free wall shows a thickened pericardium along with the thickening on the RV wall as well in the parasternal short axis view. And what we saw in the lower esophageal hepatic vein view was a very, very typical sign known as IVC plethora. You can see pericardium. As the IVC enters the RA, the IVC is dilated. This is more than 2 centimeters. The hepatic sinusoids are all engorged. And when we did a Doppler flow across this and we did the measurement and how it is entering the RA, when we did the measurement here, when this typical engorged IVC known as IVC plethora is a hallmark again of constrictive pericarditis. This showed again the same reversal of the hepatic venous paradoxes as it is called, and that's why these patients present with this kind of a mitral inflow, peak velocities being very high. The tricuspid flow Doppler also showing increased E prime velocities. LVOT flow Doppler showing a gradient around 1 only, but the VTI is about 11.2. Everything seems to be decreased. And therefore, this patient this was a patient of carcinoma actually, who had come for pericardial effusion drainage and needed a pericardiectomy. And they were thinking of a transplant because it was a young male, but this patient did not need a transplant, just a pericardiectomy, and the echo making the right diagnosis proved on MRI made it just a simple pericardiectomy for this patient. So this is the surgical exploration done where carcinoma, kind of a thickened pericardiectomy was stripped very carefully by the surgeons, and the visceral pericardium was also removed. Surgery was a very lengthy process in this patient, but we did it for the sake of his symptoms. And this patient benefited a lot. Another fifth example is a 44-year-old who had cirrhosis of the liver. And this 2D transthoracic echo done from the backside of the patient to evaluate the LV and RV function was found to be normal. Now, why are we doing the backside? Because we became so constricted about the fact that we have to rule out a lung carcinoma, or are we trying to see the pericardial effusion from the left back better, or are we checking for ascites, or are we checking for left and right pleural effusions? Well, in all these cases, we were checking for the left and right pleural effusions along with the pericardial effusion. We knew this patient had a pericardial effusion, which was minimal. So we made the patient lie up. We auscultated the back, and we moved the entire transthoracic transducer on the right bank, and we slided it over the right kidney. This is the position of the right kidney. And around the right kidney, we found this pocket of right pleural fluid. When we are seeing something like this, to check for right and left pleural effusions, it is most reliable technique to do it first from the back, transthoracically. Examinations performed with the patient slightly leaning forward, and left pleural effusion may be very well seen here in parasternal axis here. And what is it limiting? The pericardial effusion here is limited by the position of the descending thoracic aorta. Right? You're seeing the LVOT, you're seeing the RVOT, you're seeing the aortic valve. This is the parasternal long axis view. And this huge area here is the pleural fluid. And this pleural fluid goes beyond the descending thoracic aorta. So in a 5-chamber view here, when you're seeing the descending thoracic aorta, any fluid that goes beyond the descending thoracic aorta is the pleural fluid, but if it gets restricted by the descending thoracic aorta, it's the pericardial fluid. So that is the fourth take-home point for a measurement of the pleural versus pericardial effusions. When we are doing these effusions, it's important to see the large echo-free space in the LV, which shows the descending thoracic aorta here. And you can do multiple views. This is the apical view here. You could see the parasternal long axis view, the short axis view. But the short axis view will tell you the best view probably in my mind to view the aorta in totality is the suprasternal view. But you could see it from the subcostal point, and you could see it from the back. The back is a very pathognomic sign of telling you anything about a pleural fluid. And when you see these fibrinous strands in the pleural fluid, it means this is a coagulopathy coming up as well. And these subcostal views, these suprasternal views, these apical views, parasternal long axis, as well as short axis views, 5 views together help you differentiate if it goes beyond the descending thoracic aorta as it does here, a pleural effusion rather than a pericardial effusion. So this is a case of a massive left pericardial effusion, and this is how you make the patient lean forward and move forward. Now, so what is the best way? The best way to diagnose a pleural effusion is to examine it from the back, because pleural effusion is gravity dependent. It can be detected behind the descending thoracic aorta in the long axis view, but only a small pleural effusion on the right side will be missed when you ask and move the transducer along the right kidney. A part that I did mention in the first, and which I'm mentioning here again, is to cut through the RA area and see the flattening of the RA septum, right? The M mode here is cutting through the RA RV. You can see the cut through here. And when it comes through in atrial systole or early diastole, there is no downward motion. So this is known as a typical sign of atrial flattening. And this is the right atrial diastolic inversion or atrial collapse that we talk of, which is very, very pathognomic of pericardial effusions, which are bordering onto a constrictive pericarditis. Left untouched will give rise to a cardiac tamponade. So this is the descending thoracic aorta and not going beyond it. These are all the views. This is the short axis view of the LV. This is again another view which is very nicely showing the four-chamber view, the LA, the RA, the RV, and the LV in the transthoracic area from the apex. And this is another view where the posterior structures beyond the RA, the RV, as well as the coronary sinus being dilated. And the dilated coronary sinus on TE tells us an LSVC, but a dilated coronary sinus with fluid all around it tells us a pericardial effusion with, of course, maybe or not maybe a pericardial effusion with LSVC. So when you see a small equilucent space, which is less than 10 millimeters and it is small, it is a small pericardial effusion. If it's moderate, the amount of space equilucent is between 10 to 20. And if it is more than 20, it is a large pericardial effusion that you're seeing. Very often, a pericardial effusion can be mimicked with a pleural effusion. I did say descending thoracic aorta is the judging point. Epicardial fat is seen as bright, echoic, hyperechoic excrescences, which may be sessile, which may be generally sessile. They are not pedunculated, but even they could be pedunculated, but they stand apart. They're very, very bright, more echoic, hyperechoic than the normal fluid. A left ventricular pseudoaneurysm may mimic a pericardial effusion, as may a pericardial cyst. Now, as I said here, this is a very good video to show the difference between in a parasternal long axis view. This is the pericardial effusion here in this view, LV around the LV free wall. This is the thickened pericardium, the two walls you can see, and this is the pleural fluid. And this is the position of the descending thoracic aorta, right? Now, this descending thoracic aorta suggests this is a massive left pericardial effusion. This is the small pleural effusion. This is the small pericardial effusion. And this patient needs a pericardiectomy for its control. So this is the same one where I'm just delineating the descending thoracic aorta. Another long axis which tells us about the epicardial fat. Now, epicardial fat as EF that you see here would be a very typical tissue structure which could be striated. It could be hyperechoic, bright, excrescence. It could look like a hollow tube, but epicardial fat should be demonstrated as an anterior structure, and a pleural or a pericardial effusion is generally a posterior structure with thickening of the pericardium. So in a pericardial effusion, you will have a atrial collapse, a chamber collapse. You'll have the IVC plethora. You'll have a hepatic venous flow pattern, which is a reversus of the normal flow pattern and giving rise to the pulses paradoxes. There'll be an expiratory related change, which would be seen in both the right and the left ventricular sizes and the Doppler. The inflow velocities on the medial side would be greater than the lateral side, and you'll see a swinging heart, which we all know is the Beck's triad. So left-sided chamber collapse almost exclusively would be defined only when the oblique sinus, which is just behind the LA, is enlarged. When you have something like that and it becomes loculated, then you can have a collection beyond the LA. Otherwise, a circumferential pericardial effusion leading to a tamponade with ventricular diastolic compression has not been reported very commonly, but pulmonary hypertension with pericardial effusion is very, very common, especially in cirrhosis patients. A right atrial chamber collapse is an inversion which is seen first in late diastole or early systole, and it often is seen early in the course of tamponade physiology. It is one of the first pathognomic signs when you see a right-sided diastolic collapse of the atrial chamber or the ventricle as well, with hypotension, with pulsus paradoxus. And this sign of right atrial collapse exceeding 30% of the cardiac cycle, or more than 1/3 of the cardiac cycle, is a pathognomic sign for right atrial inversion, is a pathognomic sign for pericardial effusion going on to the constrictive pericarditis side. And it is best seen in a subcostal 4-chamber 2D view. The right ventricular chamber collapse in cardiac tamponade occurs in early diastole. This is the MCQ question, which is seen very, very common. And when we do a peristernal long axis view, you can see the peristernal pericardial sac. There is a dimpling of the right ventricular outflow tract. And this dimpling of the right ventricular outflow tract in the anterior wall with mitral valve opens is going to give rise to the patient some kind of a tachycardia. And timing of the early diastolic inward motion of the RV free wall can sometimes better be appreciated when we do an MOT. And when is it not seen? It is not seen when the right heart chamber signs of collapse are not seen with any pre-existing right heart pressure increases like portal hypertension or RBH. And cardiac tamponade physiology without a right heart collapse is actually quite unknown, but pyogenic tuberculosis, or a tuberculosis which is of long standing, a miliary tuberculosis with intrapericardial adhesions, however, may not show a collapse. Let's see this MCQ, and I come to the end of my talk. Which of the following parameters is not an echocardiographic pathology for tamponade? An RV early diastolic collapse is mid-systolic collapse. This is generally not there. That is the answer. It's a early systolic or a early diastolic collapse. Generally, it's a diastolic collapse, which is pathognomic. A decrease in the mitral E velocities by at least 25% during respiration, and a dilated IVC and prominent septal dependence. Septal dependence is there, dilated IVC is there. The mitral inflow velocities would increase during respiration. This decrease along with the mid-systolic collapse are answers which are not there. Echo of CT showing plethora with dilated veins is very, very common. Duration of an RV collapse more than 1/3 of the cardiac cycle, where 100% of the systole and the diastole for the entire cardiac tamponade are known, is something which is pathognomic of constrictive pericarditis. I've been talking more about cardiac tamponade, constrictive pericarditis, and a pericardial thickness, right? And this is how they go. A pericardial thickness giving rise to acute pericarditis over a period of time, a chronic pericarditis, a constrictive pericarditis, and a cardiac tamponade. And what do we see in the ICU post-cardiac surgery is generally a cardiac tamponade, which will be the acute pericarditis. So ventricles should be seen in early diastole after the end of T wave. This is also a MCQ question. And the atria indentation starts to peak near the peak of RV. Any cardiac chamber collapse, 90% negative predictive value for clinical cardiac tamponade. And how do we rule it out? By showing in a COPD patient or a pulmonary embolism patient the absence of an IVS which is shaky, a septal bounce. If you have a right atrial collapse, it may also happen in a pulmonary embolism. It may also happen in a COPD dyspneic patient. But if you have a septal bounce where the interventricular septum is shaky, along with that, you have an increase in the medial velocities more than the mitral inflow, more than the lateral, and you have a Beck's triad picture and an inspiratory septal bulge in a CT with LVH pre-existing and LV filling pressure is high, it means it is pathognomic of a constrictive pericarditis going on to a cardiac tamponade. So that was my last slide, and it should always be, the echo should always be merged with a CT imaging or a MRI, whatever is available in the institute, because these two are the gold standards. Echo brings about the diagnosis, but CT or MRI confirms it. Thank you so much. I invite all of you, any one of you who wants to join in our ECMO, or cardiac critical care, our echo, cardiodiabetes, cardiac nutrition, or patient blood management fellowships, can write to us. And I would like to thank Dr. Mulidhar for giving us this opportunity. Our latest textbook, the textbook of cardiac critical care, with a lot of authors from Narayana and a lot of authors and anesthetists from around India and outside India, is for release by the Tima publishers on Amazon. Anyone who wants it can write to us. Thank you so much. I'll be happy to take some questions. Any questions? Dr. Mulli?
Thank you so much for that excellent talk on pericardial disease and the role of echocardiography. You have covered most of the important points. There is one question which says, what is the probe position for examination from the back? You mentioned about detection of pleural effusion from the back. So what should be the probe position is the question.
Yeah, so you slide the probe from left to right, make the patient sit with the back towards you. It's a transthoracic probe that you're using. And you make the patient lean slightly forwards, and you move the patient's probe from the left lower back to the right lower back. And the cursor, the pointer of the probe, the transthoracic probe, would be always pointing upwards towards the 12 o'clock position. So you're moving the probe centimeter by centimeter from the left to the right, with some 45 degrees anterior motion and 45 degrees posterior, with the pointer always pointing towards the 12 o'clock position. That is the position in which we slide the transthoracic probe, with the patient slightly forward leaning from left to right back, and always taking care that when you do a slight indentation forward 25 to 45 degrees and posterior again 25 to 45 degrees, you have no chance of missing the pleural effusion. Normally, pleural effusion from the back would gravitate more towards the right kidney. Generally, that is the position where they see it most. But instead of starting from the right kidney and moving leftwards and displacing the fluid, it's best to start from the left side, move it to the right, end at the right, and at every centimeter that you move, with the pointer, normally we say in a apical view, the pointer pointing on the left shoulder. And then we move for transthoracic 45 degrees anterior or 45 degrees posterior. But in the back position, you keep your pointer towards the 12 o'clock position with a 25 to 45 degrees anterior or posterior motion at each centimeter that you're moving up the back of the patient. I wish I could do it on an echo machine, but I hope it suffices. I think someone's in the OT also. You have people from the OT there. Yes.
Yeah, the next question is CT versus MRI in pericardial disease.
Well, they say that CT, MRI is the gold standard over CT. But if you have a CT which is available, then a contrast CT is better than a plain MRI if it is available. What do we do at our center? We generally go in for a CT which is contrast. We avoid an MRI because of the risk of exposing it to even further this thing. But of the two, if one is available, it should be a contrast CT over a plain MRI. And if you have a gadolinium enhanced contrast on MRI, that is the ultimate gold standard over and above the echo.
More than 20 millimeters for diagnosed severe pericardial effusion is the same for pediatric population is the question.
More than 20 millimeters.
Is there any different parameter, I mean the range for pediatric patients?
No, we generally see the thickness of the pericardium for a pericardial fluid, and the volume of fluid in a pericardial effusion would be very less. Pleural effusion, if it coexists with the pericardial effusion, more than 20 millimeters or more than 20 cc, as they say, with the thickness difference, is what is given in most standard textbooks as of now. The latest guidelines on echo for pericardial diseases range back to 2019, and these have not been improved upon. I'm sure some more measurements and some more nomenclatures would be soon be coming. I couldn't lay hand on anything beyond this.
Dr. Parimala, do you have any comments to make? Any questions?
There is actually a question I saw that when CT, MRI are there,
Yes.
what is the role of echo? And perioperatively, we can't always send the patients for CT or MRI in especially tamponade situation or intraoperatively. So we make use of echocardiography. I remember one case of pericardial lipoma. It's a rare condition. Yes. But intraoperatively, we found that it was not just pericardial, it was intramyocardial. Oh. And in fact, while dissecting it, LV hole was made and urgently we had to go on CPB. So all these things we can monitor and warn the surgeons on table also. So there is a role for echo, especially in the perioperative period. This was my comment, sir.
Yes.
Actually, the acoustic window that you get from echo will not be the same as a CT or an MRI. So, but echo should be done as a first line, as Parimala has rightly said, because you don't want that much of radiation also to the patient. And the amount of the pocket of volume once seen, then a CT or an MRI is better. Now, what is the value of a CT scan over an MRI for pericardial disease? Well, anything which is 1.2 to 1.7 millimeters on an MRI image can be seen, but CT detects even a smaller range, 0.2 to 0.7 millimeters. So the range with a CT contrast is even for a smaller thickness than over an MRI. But the moment you put in a gadolinium contrast, then the two are similar. So we don't have so much of access for MRI for our in-bed patients as much as we have for our OPD. So we restrict to rule out that small increase of 0.2 to 0.7 millimeters on a CT first, and then a contrast CT. And if the patient's symptoms are not better, then an MRI last. That's what we normally practice, because of the thickness that the two CT and the MRI tell us as different. MRI is 1.2 to 1.7 millimeters thickness that it detects. Unless a gadolinium is given, then anything less than 0.5, it cannot detect.
Any other questions or comments?
But if someone asks an MCQ, Dr. Mulli, that echo, MRI, CT, which is the most accurate for pericarditis, the answer should be a CT.
Yeah, CT has a better spatial resolution and it can detect the thickening well.
But I think most surgeons' choices rule, and this is where the cardiologists and the surgeons get together, or the treating physicians with the surgeons. And our role as echocardiographers is very upcoming, especially for our in-bed patients who post-surgery may have a pleural with a pericardial effusion and difficult to detect both. I found this suprasternal thing to, just as we do it in small children, we do a suprasternal transthoracic probe to see the entire aorta, and we see the level at which the coarctation is there. So to rule out the coarctation of the aorta, you do a suprasternal view. Now with that subcostal and suprasternal view transthoracically combined, the moment you see the descending thoracic aorta and you see the fluid beyond descending thoracic aorta, you're certain it's a pleural fluid. Yeah. If it is getting limited and it has thickened layers around it, it means it's a pericardial fluid. So I found this distinction of transthoracic much better than a transesophageal, where we can't enhance the probe beyond the gastric stomach in a descending thoracic view. A subcostal or a suprasternal view is very good to see the descending thoracic aorta and tell us the difference between a pleural and a pericardial fluid.
Yes, thank you so much. I think there are some comments saying that great lecture and a wonderful talk. Thank you very much. And there seem to be no more questions. I would like to thank both Parimala and Dr. Poonam Malhotra for being with us this Sunday morning for the breakfast session. Thank you very much. We'll see you again next week. Please join us. There will be an interesting talk by Dr. Mahala on role of echocardiography in acute coronary syndromes. Very important topic. Please join us and enjoy your Sunday. Thank you so much.
Thank you, Dr. Molly, for the opportunity. Thank you, Parimala. Thank you, Rajiv. Thank you to all. Thank you.
Thank you.